Good evening, everybody, and my name is Tim Williams, and on behalf of BOFAS, I'd like to welcome you to tonight's lecture of distinction on the crushed foot. As previously, the plan is a roughly half-an-hour lecture, followed by a Q&A opportunity. The way to ask questions is to use the Q&A icon at the bottom of the Zoom screen, and I'll try and filter these through to our speaker this evening at the end of the lecture. This will be the 8th in our series. And that means that it's time at last that we can provide certificates of attendance. These will be sent out once we receive feedback from tonight's talk, and they'll be sent direct through to your email. Those of you who are new, what will happen is when the webinar closes, you'll receive an email detailing you how to access the feedback website, and upon completion of it, a certificate of attendance will be sent out shortly. All the lectures continue to be videoed, and they're all accessible using the BOFAS website. And if you look under the Educational Resources tab in the top right-hand corner of that webpage, you can access all the videos in both audio-visual and just audio lectures for ongoing education, both now and, of course, when it comes towards your exams. You'll note to my right that there is a slight change in the timetable over the next few weeks. Most notably, I think most of you realise tonight, they're all going to be done at 8 o'clock in the evening rather than the earlier 7 o'clock in order to make sure people can get home and get started on time. The other one to note is the new date of October the 12th, which is now going to be a paediatric foot problem talk from our very own Education Committee Chairman, Mr. Rick Brown, and his colleague, Mr. Alpesh Kotari from Oxford University Hospitals. So, my final thing is to introduce tonight's speaker. Mr. Arul Ramasamy is a foot and ankle consultant in Buckinghamshire, having completed his fellowships in Birmingham, Oxford and London. He is also a trauma expert, having a military role that saw him serve as regimental medical officer for the British Army with tours to Iraq and Afghanistan. He continues to serve treating military personnel. Out of this, I'm sure, came his interest in research, and that saw him obtain a PhD for foot and ankle trauma. He now supervises multiple other PhD students studying projects of their own. He is a previous ABC Travelling Fellow and current foot and ankle editor for the Bone and Joint Journal. Presenting tonight's lecture of distinction from BOFAS, I have the great pleasure to introduce Mr. Arul Ramasamy. Thank you, Arul, and over to you.
Thank you, Tim. Welcome, everyone. Good evening. So I'm going to talk about the compartment syndrome of the foot and the crushed foot. So there's basically two talks in one. The first half, we'll talk about compartment syndrome, review pathophysiology, some of the current controversies, and some of the principles of management. And then we'll look at the crushed foot in terms of its immediate management, whether you should keep it or whether it should go. If you're going to salvage it, what the principles and some of the outcomes of it. Some of this will hopefully be revision for those of you going towards the exam.
Arul, do you want to start your slideshow?
Sorry. Yeah. So compartment syndrome itself is relatively uncommon. It's part of probably maybe 2% of isolated foot trauma and less than 5% of limb compartment syndrome. So something that we don't often see. Papers would suggest that compartment syndrome is typically associated with severe crush injuries, but also severe forefoot injuries as well. Some papers have suggested that compartment syndrome occurs in up to 10% of calcaneal fractures, but rarely do we do fasciotomies, and most papers suggest that it's under 1% of calcaneal fractures that undergo formal fasciotomy. So the pathophysiology of compartment syndrome, I'm sure many of you know. You get increasing pressure within an elastic osteofascial compartment, and that can be intrinsic or extrinsic causes. Intrinsic causes can be things like bleeding and edema. Extrinsic causes could be constrictive splints or burns. The compartment pressure increases, and eventually it will be beyond the capillary perfusion pressure. Once that happens, you get ischemia within that compartment. Prolonged ischemia leads to muscle death and nerve injury. And then finally you get necrosis, fibrosis, and contracture of the compartment's contents, leading to that classic Volkmann's contracture. So what are the complications of untreated foot compartment syndrome? The most common complication is claw toe, and that's because the fibrosed or weak intrinsics are overpowered by the extrinsics. You can get fracture hematoma in the deep central compartment that compresses the medial and lateral plantar neurovascular bundle, often seen in calcaneal fractures. That again leads to ischemia of the interossei and the quadratus plantae, leading to a claw toe. Contracture of the plantar structures can lead to a cavus deformity. And you can also get neuropathic pain due to nerve damage from ischemia and insensate foot, and in combination with deformity may lead to ulcers in the future. So what are the signs and symptoms? In every other part of the body with compartment syndrome, it's about pain, severe, relentless, burning pain. Pain that progresses despite splintage or increasing analgesic requirements. Within the foot, Manoli et al. Found that the most consistent finding was a tense swelling. Typically for lower leg compartment syndrome, we're always taught to move the toes as a sign of whether passive movement causes pain. In foot compartment syndrome, it's probably not helpful. If you have major foot trauma, unsurprisingly, if you move people's toes, it's going to hurt. Sensory changes are also not reliable, a late sign in lower leg compartment syndrome, but in the foot, even a small amount of swelling can lead to sensory changes. I think the key to this really is serial examination of the foot. Seeing the foot from the very beginning and watching it progress, seeing whether it becomes more swollen, more painful. These are the things that are probably going to guide you towards a diagnosis of foot compartment syndrome. What about pressure monitoring? As in the lower leg, if a particular compartment has a pressure greater than 30 millimeters of mercury, then that would suggest that you've got compartment syndrome in that particular compartment. In a 12-patient study, Mittelmeier found that the patients who had calcaneal fractures and a compartment syndrome greater than 30 had poorer outcomes than those that didn't. But it's not just the absolute compartment pressure that dictates whether you've got compartment syndrome. It's also whether there is a narrowing of the pulse pressure between the diastolic pressure and the compartment pressure. And if that delta P is less than 30 millimeters of mercury, then you can also consider that compartment at risk. So where do you measure it? There are several locations where you can measure the compartments because there are so many compartments. The medial and calcaneal compartments can be measured on the medial side, about 6 centimeters distal to the medial malleolus. The superficial and deep central compartments can be measured about 11 centimeters from the sole of the foot, from the heel. And then the lateral interosseous compartments can be measured about 10 centimeters from the lateral malleolus, working its way across the top of the foot. In every other part of the body, if you suspect compartment syndrome, the exam answer is fasciotomy. It's simple, right? And if that was the case, this talk would be over in about 4 minutes and you're going to go and have a drink. But unfortunately, foot and ankle surgery is a little bit more complex than most things. And there are a number of controversies associated with this. And they include how many compartments are there? How do you perform a decompression? What are the consequences of decompressing that foot? And actually, what are the outcomes in foot compartment syndrome? What actually happens to our patients? So you think this would be a pretty simple question, and for the rest of the body, it's pretty simple. How many compartments are there in the foot? Either the foot has evolved over the last 70 years and we've grown more compartments, or we don't have a clue. And I think it's probably the latter. For those of you who are avid fans of gynecology journals, would have read Grudinsky's paper in 1929 in the Journal of Obstetric Surgery, and he classically described 4 compartments. We then went down to 3 in the 60s, and then since then we seem to have grown compartments, and we're now up to about 10. So of the 10 compartments, you have the 4 interossei, you have 1 medial, 1 lateral compartment, you have the superficial calcaneal compartment, and then you have the deep calcaneal compartment that involves the quadratus plantae, and then the adductor compartment that has adductor hallucis. And more recently, we've been considering the skin as that 10th compartment. Hopefully, the foot won't evolve any further before your exams, so we'll stick between 9 and 10. So how do you do a fasciotomy? Well, the most common is the 3-incision fasciotomy. You have a medial incision, and that's 4 centimeters from the back of the foot and 3 centimeters superior to the sole of the foot. And in theory, that decompresses the medial, superficial, and deep calcaneal compartments and the lateral compartment. You then do 2 incisions over the dorsum of the foot, one medial to the second metatarsal, avoiding the neurovascular bundle. So it's not a slash and burn operation. You do actually have to take some time and dissect things carefully. And then the third incision lateral to the 4th metatarsal. And the idea is to decompress the interossei and the adductor compartment. It's not without controversy, and other papers have suggested that there is a single incision approach. This was a cadaveric study performed in Singapore, and they thought that the fascia encasing the interossei wasn't fully there. So they thought you could do everything through a single incision in the sole of the foot, but then there are no studies to report on its effectiveness. But just something to think about. So what are the results of fasciotomy? The aim of fasciotomy, obviously, is to decompress the compartments and therefore prevent some of the sequelae of a Volkmann's contracture. Myerson reported the first series, and that's 14 patients. And unfortunately, with foot compartment syndrome, you're not going to have hundreds of cases. So in their 14 cases, 11 of those required split skin grafting after fasciotomy. 1 required a free tissue transfer. And at the end of it, 4 were symptom-free. Now, they say that that was a success and patients were generally happy. And I think it depends whether you're a glass half full or half empty sort of person. I would suggest that that's not a fantastic result. Fakuri and Manoli presented 12 cases where they had 4 that required skin grafting and 8 out of 12 had discomfort and stiffness. More recently, Han et al. In Singapore discussed 14 cases, of which a 5th developed a claw toe, a 5th had ongoing sensory deficits, 30% required some form of footwear modification at 2 years. And they did find that the results were slightly better than those who had an earlier fasciotomy, i.e. within the first few hours compared to those that were delayed over 12 hours. So what are the issues with fasciotomy? Because if it was completely without issues, it would be an easy solution. The problem is that your location of incisions may not be optimal to reduce and fix your fractures. If you have a complex talus fracture or a complex midfoot fracture, these 2 incisions are not going to be ideal and make your fixation more difficult. You've got to remember, in foot compartment syndrome, rarely is it isolated. It's often part of polytrauma, and you're not going to have 4 hours at the initial surgery to be able to fix all that you need to fix. And therefore, with these large incisions, you're basically converting a closed injury into an open fracture, and it may be a significant period of time before you can return to theatre. And that obviously has the risk of infection and all the complications associated with that. There is a risk of nerve injury, particularly on the medial plantar nerve from the medial incision, something you need to be aware of. And finally, you've got to think about the functional problems. Myerson already commented that a significant proportion require skin grafts. Split skin grafts are relatively easy to do, but they're not great in terms of durability of skin. So looking forward to this patient who's trying to get back into their footwear, they may then struggle with rubbing, which may then cause problems. You may also have issues with the skin graft breaking down in the future. And also skin grafts generally tether to anything underneath. The tendons themselves are very superficial, so it's likely that you then get tethering and problems with the toes because of it. So is there another option? Well, there might be. Dunbar et al. From Harborview in Seattle suggested the pie crust technique. And essentially you go on the dorsum of the foot for a very swollen foot, and you make multiple 3 to 5 millimeter skin incisions with a number 15 blade. As you can see in the bottom right picture, there's multiple stab marks. And then you use a hemostat to go into each incision and evacuate the hematoma and spread the deeper tissues. And those photographs were taken on the same day, and you can see how quickly the foot can be decompressed and you can save the skin. It is important that it's not just the skin incisions. You do need to use the hemostat. You do need to try and get into those compartments. It can be argued that you're not going to get into the deeper calcaneal compartments, but certainly for the dorsum of the foot, it seems to be very successful and allows the foot to recover quickly enough to allow secondary survey in a shorter period of time. Sargent and Poon described their series in military patients in Birmingham, where we used this pie crusting technique in combination with negative pressure therapy. And you can use the negative pressure therapy to act as a splint by putting the foot in the right position. And they show that you could decompress the foot very quickly, and now allowing you to get to the second stage of definitive surgery much sooner than you would if you had to allow for all the swelling to settle. Unfortunately, there's no clinical studies to report its effectiveness, but it seems quite a sensible and relatively issue-free procedure. But the real problem with compartment syndrome is that it's difficult to know if the sequelae of foot compartment syndrome is a consequence of that compartment syndrome or secondary to the mechanism of injury. As I said earlier, the most common cause of compartment syndrome is that severe crush injury. And therefore, it's likely that that mechanism of injury is going to cause significant damage anyway. If we look at the effects of neglected compartment syndrome, we're really talking about claw toes and archaious foot deformities, but they can be corrected relatively straightforwardly or can be accommodated with orthotics and footwear. Neuropathic pain is still an issue, but the question is, by doing the fasciotomies, have you made a huge difference, or have they got neuropathic pain because you've crushed the foot? So it's difficult because, unlike elsewhere in the body, decompression in the foot is not without risk, and yet the outcomes are still not great. I would suggest that maybe pie crusting offers an opportunity to reduce that swelling without the risks associated with large fasciotomies. So that's my personal view. I think consider decompression only if the foot is grossly swollen, where the skin is taut and is at risk, and the patient is in severe pain despite splintage and analgesia. In my hands, I think I perform the pie crusting procedure first as a damage control procedure to reduce the swelling. If, having done that, the foot still remains grossly swollen and hasn't really decompressed, then I would convert that to a formal 3-scission fasciotomy, which isn't particularly difficult because essentially you're just joining up the dots. That's probably controversial. There's no evidence behind it, but I think that seems to me to be a sensible way of managing that foot. So moving on to crush injuries to the foot. It is rarely an isolated injury. It's often part of polytrauma, but like all limb injuries, it's very distracting, especially to ED personnel, but it's unlikely to be the thing that's going to kill your patient. That said, it is a cause of significant disability. So if you look at patients who ended up in intensive care with polytrauma, those with foot and ankle trauma had significantly worse disability scores and outcome scores compared to those that didn't, underlying how important your feet are in order to have a decent quality of life. But why is the foot so vulnerable in a crush injury? It's an end organ, and therefore it has small caliber blood vessels. If you damage blood vessels in the foot, it's unlikely that a vascular surgeon is going to be able to repair them. It has a very thin, fragile soft tissue envelope with multiple subcutaneous bones, and therefore that envelope itself is very vulnerable. Finally, it has specialized plantar skin that's difficult to replace. You can't put a split skin graft on the sole of the foot because it's not going to work, and therefore you have to be very careful with the sole of the foot. And if that dies, then you're going to have difficulty reconstructing that foot into something that is usable. So what is the immediate management? First of all, the exam answer is ATLS, preserve life and limb. The foot is not the most important part. It's a horrible thing to say on a BOFAS talk, but apparently it's not. You need to evaluate the foot. Check pulses, document with Dopplers, assess the soft tissues, fractures, X-ray or the trauma CT, and then assess neurology. Previously, we always thought that plantar sensation was an indication for amputation, but we know that's no longer the case, and I'll discuss that in more detail in a second. So what are you going to do in ED? Antibiotics as per your local protocol, anti-tetanus, photograph the wound, saline-soaked gauze dressings, and then splintage. When would you consider an amputation in this situation? Really, I think there's probably four main reasons: as part of a non-viable limb and the presence of life-threatening injuries where you have to remove the limb in order to save the patient. I think where you have a grossly contaminated foot that is clearly non-viable, that's probably an indication for amputation. Irreparable vascular injury or a warm ischemia time greater than 8 hours. It's really important that you do not amputate because you think it's unreconstructable. You should be able to discuss it with a specialist centre if possible. And certainly, in most cases, it can wait for the second surgery. I think it's important that you can discuss this with the patient, and that's where the photographs become useful, because you can show them the state of their foot, explain things to them, and explain why that foot's not going to recover. Most importantly, I think it's important to take the message that plantar sensation is not an indication for amputation. The first studies from that came from the LEAP study from Boss et al. In 2005, and they showed that 50% of patients recover sensation over 2 years. In our own military data that we published in JBJS a few years ago, almost 90% recovered sensation. From the military, we have a number of guidelines that we use for considering amputation, and I think these are useful in a civilian setting as well. It is important to document your exam findings and your indications for amputation. I think it's important from a medical legal point of view, but also I think to explain to your patient why you've done it, because they're obviously not in a fit state to remember why they've had an amputation. Importantly, limb salvage scores should not be used. There's lots of evidence that suggests that using a limb severity score, such as mesh scores, doesn't really help in deciding whether you should amputate or not amputate. Very much in mesh scores, you'll know that a very low score means that you shouldn't amputate, but a very high score means that you should. But that's not very helpful, since the majority of patients are in the middle, and the scoring system doesn't help at all. Photograph all the wounds, and do make sure that you obtain radiographs prior to amputation. So how do you do the operation? Really, the site of amputation should be the lowest level possible, and it shouldn't be a guillotine amputation. I really consider that amputation in that trauma setting to be a radical debridement. You are trying to get rid of devitalized tissue. It just happens that that devitalized tissue is the limb. So don't fashion flaps at your initial debridement, because you don't know what state it's going to be on, and you may need further debridements in the future. Bones should be cut at the most distal soft tissue level, and amputation should not be carried out at the level of any fracture unless this is at the same level as the soft tissue. Make no attempt to close any part of the wound at initial surgery, and do not attempt to prevent skin retraction by leaving sutures in there to hold the skin. It doesn't help. So that's the worst part of it, where you feel that you might want to amputate, but actually the vast majority we can consider limb salvage. And I really feel that this is much a part of damage control surgery. And there are three elements to damage control surgery of the foot. You want to look after the skin, preserve the soft tissues, and stabilize the bone. So in terms of the skin, again, I'd go back to decompress that dorsal skin, that very swollen dorsal skin, because if you leave it there for days on days, it'll produce blisters, and it may get necrosis and may be compromised. So pie crusting or a formal 3-incision compartment decompression. In terms of the soft tissues, you're really looking at how do we debride. And the aim of debridement is to leave a wound devoid of foreign material and non-viable tissue. And the aim is to leave a clean, healthy bed for soft tissue reconstruction. In terms of wound excision, this is not the time to be Hannibal Lecter. Skin is resistant to trauma and has a great capacity to heal, so excise the skin edges minimally. especially in the foot where you don't have a lot of skin to play with. In terms of wound extension, I think that's important. It's easy to try and prevent further damage, to just stay within the wound, but you do need to extend those wounds proximally and distally to try and find a zone of uninjured tissue so you can find the extent of injury, so you're not leaving any dead tissue behind. Debridement can be quite a difficult thing, but here are some of the 4 C's to consider when you're considering whether a tissue is viable or non-viable. The first C is colour. Dead muscle is often dark and discoloured, and obviously you'll do your debridement without the tourniquet. Consistency. Muscle has that elastic consistency. When it's dead and it's non-viable, it's often mushy. Contractility. If the muscle is alive, it will contract when crushed with forceps or touched with a diathermy probe. If it's dead, it'll do nothing. And then look for capillary bleeding in the soft tissues. In terms of loose bone fragments, if they have no soft tissue attachment, then they have no purpose and should be removed. So if they fail the tug test, then they need to go in the bin. And finally, the bone. You are unlikely in that damage control situation to have the time to do a massive forefoot or midfoot reconstruction. You're trying to get the foot back into a shape that looks remotely foot shaped so you can come back and fight another day. And I'd argue that simple things like forefoot K-wires going through the metatarsal head and down the metatarsal shaft are very helpful. For the midfoot and hindfoot, you can use a combination of K-wires or an X-fix. You want to keep the foot as shaped as normal as possible because you may be a while before you get back to surgery, especially in these significant polytrauma patients. It may be several weeks before you can get them back to theatre. So at least you have something that stabilizes the bones in a relatively normal position. You give the patient the opportunity to at least leave hospital with a foot-shaped foot, which they may be able to get into footwear, which is probably a win for them. And I think when you think about crush injuries to the foot, and this is not like a simple crush injury where someone drops a small stone or something on them, but significant crush injuries, it's important to explain the prognosis to patients from the outset. This is a devastating injury. This is not an injury that they can just shake off and go home with. And I think it's important that you explain to them very carefully that they are going to have a very severe effect on their lives, and so they can plan accordingly. At 5 years, a significant number will still have chronic pain. They'll still be in your clinic. A significant number will have foot stiffness or residual deformity. A large number will have symptoms of CRPS. Very few will return to work, and most will walk with a limp. And I think it's important that you explain to them that even if you salvage their foot, they may never get back to where they were before. And so they can plan for that. And that is compartment syndrome of the foot and crush injuries.
Arul, thank you very much indeed. A brilliant talk and a great run through what is quite a devastating and complex area with quite a lot open for discussion, I think, isn't there? Still, we've got a bit to learn in this field and what is right, what is wrong. I love your pie crusting thing. I haven't used that. I think that's very, very interesting. There's a few questions coming through on the chat.
Yep.
Which actually one of them goes exactly with that point. Do you think there's any place for hyperbaric oxygen treatment, improving tissue viability?
There is some evidence that it works. It's not great evidence, but there is some evidence. I think the issue mainly is availability of services. And the issue is that in these patients who've got polytrauma, how do you get them into a hyperbaric chamber when they're still on ITU? So I think, yes, it probably has some role, but I think it's going to be very limited.
And going back to the beginning of it, there's a question here. When you're suspecting compartment syndrome, in the lower limb, we sometimes put in these devices to measure the compartment syndrome and then watch it and monitor it. Do you use that in the foot at all?
I think it might have some option, role in that ITU patient, potentially. But the real question, and I think, and I never found a right answer for this, is can you convince yourself why you're doing it? As in, you've got this patient who has a swollen, horrible foot, and then you're wondering, if I decompress them, you're doing it really for pain relief. You're trying to get them out of the fact they're in agony despite being in a splint. Because you know the consequence of doing your fasciotomy are quite significant.
Mm-hmm.
And actually the consequence of leaving it is not as bad as other things in terms of the claw toes and the cavus foot. We can just about manage with that as a consequence. The neuropathic pain is an issue, but I don't know whether you decompress it, whether it changes that problem at all. So I've never measured, generally I haven't measured the compartments because I'm not sure how helpful that is.
I agree. I don't use it either. It's just clinical suspicion and insight and watching the patient, isn't it?
Yeah.
That kind of leads on to the kind of next question about it. Is therefore, are you reducing the number that you're doing rather than increasing the number that you're doing, so to speak?
I think so. I think I'm probably, if I'm faced with it, I think I'd go for the pry crusting first. I think I've seen it happen, and I've seen that foot decompress very quickly. And that allows you to come back to operate and do your formal surgery at a later date. And I also think it doesn't really queer the pitch in terms of your incisions, because trying to do some complex footwork with two big incisions that don't really help you, that makes the operation even more difficult than it already is. So my gut feeling is that maybe pie crusting could be the way forward, but I have no evidence for that.
And once you've done your decompression, would you, at the same time when you're decompressing it, or the guys are decompressing it at night, would you ask them to stabilize it there and then with wires as well if possible? Or is it just the decompression, stop and splint, and then come back to the fractures at another day?
I think that really depends on the experience of the surgeon, on the foot. A lot of things can be just reduced and held in a splint or a plaster, but if it's very wobbly, you might want to think about putting some K-wires just to hold it in place to give that little bit of extra stability, and then come back and fight another day. It really is damage control surgery. You're just trying to get the foot vaguely foot shaped and then let someone else who knows what they're doing or is more experienced in the cold light of day to do something else.
And you mentioned the opportunity about the option of potentially using an X-fix across it. Have you used that? Which particular scenarios have you found that a useful tool over K-wires?
I think mainly in places where you have a really unstable joint, especially across the midfoot. So if you get a big talonavicular dislocation or through the Chopard joints, that's very wobbly. You're not going to be able to hold that with K-wires. And I think in those situations, it's useful to put an X-fix across the foot, and that probably is quite handy.
Mm-hmm. Just one of the questions here is in brief, where would you tend to put your pins for an X-fix on the foot for a kind of midfoot, hindfoot dislocation here? That's
a really difficult question because it all depends on the injury pattern, really, doesn't it? So if you haven't got much of a talus, you can't really put a pin through it. So I think it all depends on the injury. I mean, obviously you're going to try and get it into the metatarsals, but you might not have much of a metatarsal to put it in. And I think it depends on what you're trying to reduce. So it's a difficult one.
And having done your pie crusting intra-op decision for decompression, how long would you wait and review afterwards before considering coming back again? Is it something you do there and then the surgical at the moment, or is it something you wait a few hours and see how the pie crusting has gone?
Oh no, I think you get an answer pretty quickly. The foot decompresses very quickly, actually. I think a lot of the swelling that we see in that grossly swollen foot, a lot of that is superficial hematoma, and actually it's almost for decompressing that 10th compartment, which is the skin. And I think you'll find that once you actually do it, the foot reduces in shape very quickly. Those photographs from Seattle were pretty much the beginning and the end of the operation. And I think as soon as you actually decompress it, the blood just pours out. Yeah. And it's quite surprising how quickly the foot looks foot-shaped quite quickly.
And if you're in that situation, you getting your plastic surgeon involved on the day that you're going to decompress them? You're ringing them at night and saying, right, I'm going to fasciotomize the foot. Do you want to be there? Or is that something you do at a later stage?
I think it's a later stage. I think the initial stage is damage control. You're just going to release the compartments. You're going to protect the foot. And then probably on the cold light of day, because these things never happen during working hours, you can then reassess the foot. And that's probably when your plastic surgeon's going to come along. Because I'm not sure how much help they are in that first period of time. I mean, obviously in a big trauma center where you have lots of plastic surgeons who do a lot of trauma, they can be helpful in terms of assessing soft tissue viability. They do a lot of that and they may be helpful, but that's, I think, a skill that we should have and do have to deal with that emergency situation. Okay. I think it's important to realize that this is a dynamic situation. It's not that you do a decompression and you debride the foot and it's perfect. You know that that's going to evolve over the coming days. That depends on the patient. They could be on inotropes. You could come back 2 days later, 3 days later, and realize that actually there's a lot of dead tissue there that you actually thought was viable. And actually, that's probably not such a bad thing. I think if you go for a really radical debridement first time round, you've probably gone a bit over Hannibal Lecter, and you've probably taken stuff that may have actually survived. And therefore, I think if you find that you come back a couple of days and there's a small area that you've missed, that probably means that you've probably been just about right. And that sort of marginal excision is probably better than rinsing the foot.
So getting it stabilized first go and then always coming back for more, isn't it?
Yeah, this is the first stage on a long journey for these patients. They will have multiple trips for surgery for all sorts of other problems that they're going to have. This is going to be one of their issues out of multiple, probably.
And with that in mind, if you're in the crushed foot situation where you've got quite significant soft tissue loss, do you use a lot of negative pressure wound therapy in that situation? Do you like back?
I do. I think we've used it very successfully in our military patients. It helps with exudate control. You can use the negative pressure therapy often to splint the foot at the same time, which is very useful. And it also helps with smell and all the other things, especially if they've got multiple wounds everywhere. It actually is a very useful tool. I understand that studies like Wolf have shown no difference between simple gauze dressings and negative therapy, but I think there are other advantages to negative therapy rather than just whether it causes wound infections or wound healing.
Okay, and again, if our colleagues have decompressed it in the night and stabilized it with the K wires for that kind of Liz Frank fracture dislocation crush, do you like to have the wires just sticking out, or do you prefer them to be buried under the tissues? How do you like to be handed a foot the next day, so to speak?
I don't mind if it's hanging through the skin, to be honest, because if I know that I'm going to go back in the next 2 or 3 days or the next week or so, then that's probably not so much of an issue. Maybe more of an issue if you think they're going to be on ITU with a massive head injury and they're going to be intubated for months and for weeks and weeks, and you might not be able to get back for a while. But I think that's quite unlikely. I think the vast majority you probably can get back, and it's often the state of the soft tissues that will decide when you want to take them back to theatre. So if the wires are out, I don't have a huge issue with that, but I can see some advantages of having it buried. But sometimes that can be a real pain once they've been buried and you're not quite sure what's happened.
And with your pie crusting technique, do you find that enables you to then make an incision more how you wish for definitive fixation later on?
Yeah, that's what they reported in the paper as well, is that essentially, because you've got these tiny little holes, they epithelialize really quickly. Within about 5 to 7 days, they epithelialize quite quickly. But even if you're going to go in before then, you can pretty much join the dots. So you can pick which lines you want to go and actually just join up the little stab incisions. So I think actually it gives you that versatility and that flexibility to put the incision where you think it should be rather than being driven by the compartment release.
So in essence, for the exam, we know we've got the 3 incision technique, but then yours is definitely something that they could consider, and you look at what the injury was, what was involved, as whether pie crusting type technique is a newer technique that could be considered. Would that be a kind of fair answer?
I think so. I mean, there's no evidence for anything really. I mean, compartment syndrome of the foot doesn't have a huge amount of evidence either way. And I think I've shown with papers that have been published, which are all small studies, have shown the results aren't fantastic. So if less is more and you can actually get away with the pie crusting, I think that's a reasonable answer. And I think if you can reference the papers and show that, I don't think that's an answer they can argue with. And if they push you, then you say, I'll do a 3 incision compartment decompression, understanding that it's not without risk and it does have an effect later on.
And with that kind of 3 compartment thing, do you always do all 3? If you're going to do it, you do the lot? Or if it's a forefoot injury, just do the forefoot?
I think you should do all 3. I think it's very difficult because I think what you'll see is when you see these feet, the reason that you're doing them is that it's grossly swollen. And you can't be 100% sure that it's all just because of forefoot swelling. Just because you haven't seen a hindfoot fracture or an injury, it doesn't mean there hasn't been bleeding there. And I think it's in the same way that you do any other compartment decompression. I think if you're going to make the decision to decompress, then you should do all the compartments, because otherwise you're leaving I think part of that is that having done the incisions, someone else has assumed that you've done a full decompression. That is the assumption. And if you've missed one of those compartments, then that could be an issue because someone else has thought that you've done something that you haven't done. So I think you should, if you're going to go down that route, do it properly.
And it's a slightly interesting question here. What is the probability of a patient getting compartment syndrome again once they've had it before?
I think
Difficult one, a weird one.
I don't know. I think that's quite uncommon.
Yeah.
As in, if they've had a fasciotomy and released, I think it's probably unlikely. I mean, it could happen, I suppose. There's no reason why it shouldn't, but I think you're going to be pretty damn unlucky to have a second significant crush injury to it, or have a second compartment syndrome if you decompress properly.
And with this pie crusting, there's a little technical question here. How deep do you go? Is it just through the skin, down to bone?
So you just go to the skin with a knife, and then you just take a little mosquito clip, and you go as deep as you kind of feel, really, as deeper you can get away with, to allow the blood to go. You will know when you have that give, and you know when the blood starts coming out.
And a question here relating to your more military thing they're asking is, what's your clinical experience with significant soft tissue injury and bone loss requiring masquelade technique? Maybe you could possibly talk through that.
I haven't done that, and that obviously depends on obviously on the bone and on your patient. The results are, it's difficult because it's not just the bone or the infection that's a problem, or the bone loss. It's also the soft tissues and everything else, and it becomes a much more complex thing. And I think with those, it's probably one of those MDT things with a plastic reconstruction surgeon, whether you're going to frame or do a masquelade. So it certainly has a role, and it has been used in the third world. We haven't used it massively in the military population.
Could you just explain a bit about masquelade and what it is?
So masquelade is basically when you have you're basically trying to create a membrane. So you put a cement spacer to create a vascularized membrane, which you can then at a later date take that spacer out and put bone graft in, vascularized bone graft in, and the idea that blood supply to that area is improved to allow that for that bone to heal, in simple terms.
Excellent, Arul. I think that's it. We had some really good questions come through there. I think you showed that you had a case. Maybe we could just have a little run through, maybe bring through and reiterate some of these points. You want to screen share again?
So this was a guy that we treated in Afghanistan. There was a soldier who was involved in an explosion. You can see that the foot's pretty swollen. It's probably about 3 times the size of the other foot. I didn't have a picture of the other foot, but it was about 3 times the size of the other foot. And it was grossly swollen. He had significant pain. He was involved in an explosion, so he had a blast injury below the foot. He had a massive midfoot disruption, talonavicular joint dislocation, cuboid was in pieces. And we decided to do a fasciotomy. This was in Afghanistan. And I think we did the fasciotomy rather than a pie crusting, because you have that issue of the long delay a delay in travel time. So you've got several hours to get back. And what you don't want to do is have a foot that's partially decompressed and then in midair where there isn't a surgeon on board to be able to do that. So you're better off doing something far more formally so that it allows them to transfer back.
And when you get, often you see these kind of exploded midfoot, and you see these kind of cuneiforms that are almost falling out. You tend to kind of thumb and push them back in and try. Well,
that's pretty much what we did. I mean, we kind of KY'd it and put it in a splint and sent him home. And he did reasonably well from a fracture point of view. The swelling settled. He then had split skin grafts. They didn't do so well. They kept on breaking down. They're very difficult to use, the split skin grafts, when you're wearing boots, because they rub, and that became a bit of a problem. His toes were quite tethered. He had some clawing. He had quite a bit of neuropathic pain, which we kind of got under control. He then, sort of a year, ended up having a free flap over one of the fasciotomies. So now he's ended up with a big burger attached to the top of his foot, which means he still can't wear footwear. And then he's going to wait another year to 18 months to have that thinned down by the plastic surgeons. So you're then left with a patient who's been several years down the line, unable to wear footwear, has had these big fasciotomy scars, and he's had issues with those. And you do wonder, and the question that he will undoubtedly ask is that worth it? Or should I have been better off with a below knee amputation, having gone through a whole limb salvage process for several years with no real end in sight, and left with a painful, stiff foot at the end of it, but now with a big free flap? So I think that's always the difficult thing. And that's probably why it's kind of changed my view about whether we should be doing fasciotomies or not, because I think the outcomes are probably the same whether you do or don't. And I do wonder whether the consequences of doing that are quite significant in some patients. And actually, you might make them worse by the fact that you've given them a free flap or a skin graft on the top of the foot.
It's interesting, isn't it? It's a devastating injury.
It is.
Just out on those pictures there, what are the landmarks you were using for those 2 incisions?
So I go medial to the second metatarsal.
Yeah.
And then just lateral to the 4th metatarsal.
What, with the idea being to get your hemostat either side of the metatarsal into the interosseous spaces?
Yeah.
Okay. There's a couple of other questions coming up through here about this. If he was on anticoagulants, would you obviously reverse them?
Yes, I think you have to.
Yeah. And do you routinely use antibiotic administration when you're doing it? And if so, do you ever put any beads in the foot in the crush situation?
I think it all depends. You can do, but fundamentally, it's about your surgical. Antibiotics do not cover for poor surgery. If you don't adequately debride the wound, if you don't remove the non-vitalized tissue, if you don't get rid of the dead bone fragments, then antibiotics aren't going to be helpful. I think you have to do that surgical debridement properly and then antibiotic cover on top of it. We do know from military trauma that if you give antibiotics early, it reduces infection rates, and therefore it's an important part of it, but it's not the most important part. It's your surgical debridement and your ability to remove that devitalized tissue that's probably going to reduce the infection rate in the long term.
What a great way to summarize it. That's absolutely true, isn't it? There's a slightly more subtle question here. If you've had somebody who's had a post-operative compartment syndrome from an elective procedure or a more standard procedure, maybe than crushed foot, do you, in that situation, consider your pie crust technique, or would you just routinely open up the surgical wounds that have been performed?
I think I'd open up the surgical wounds that have been performed because you've already got the wounds there. I think putting a whole lot of extra wounds is probably unnecessary. And I think if you think you're going to get compartment syndrome, it must be something that you've done. So you can assume that those are the compartments that you've probably affected. So I would say that I'd open up the scars that you already have rather than adding further insult to the foot. But I would have thought that's pretty rare. I've never seen compartment syndrome in the foot after elective surgery.
No, I haven't either. No, I agree. The only other time I've used your pie crusting technique is when I've seen a very swollen foot where I can't get the wound to close. You can pie crust to one side or both sides of the wound, kind of give you that little bit of elasticity. And sometimes get your major wound closed, can't you? It's a technique.
I mean, that's kind of just, you're essentially sort of latticing the skin, aren't you, to allow that to close over.
I think we should move on there and leave it. And if you very kindly give your conclusion slides, that'd be fantastic.
Okay. So in conclusion, if you get neglected foot compartment syndrome, you're going to get claw toes, a cavus foot deformity potentially, or neuropathic pain. It's most commonly in crush injuries, and be particularly careful when you're looking at that forefoot crush injury. In the back of your mind, if you see a calcaneal fracture, someone who's in severe pain despite analgesia, consider foot compartment syndrome. It is up to 10%. Really, if the foot is very, very swollen, isn't getting better, the patient is not settling despite lots of analgesia and splintage, I would say consider the pie crusting technique or then the 3-incision fasciotomy. Do remember that unlike other parts of the body, decompression in the foot is not without risk, and functional outcome may be poor due to the mechanism of injury rather than purely by the foot compartment syndrome. They're probably a combination of the two. In terms of crush injuries, I think most important thing is that it's probably not the most important part of the patient at that moment in time. It's rarely an isolated injury. Do consider ATLS. Attempt limb salvage if at all possible. There's very few reasons to take the foot off at the first operation. Really consider the damage control as 3 parts. Manage the skin with pie crusting or fasciotomy. Assess the soft tissues and debride it adequately to make sure there's no non-viable tissue. And in terms of the bone, consider initial stabilization with X-fix and wires. You're really trying to do something that gives the foot a foot-like shape so you come back and fight another day. And remember, as early as possible, warn the patient of the poor functional outcome. They need to be aware of what's going to happen to them. Thank you.
Mr. Arul Ramasamy, thank you very much indeed for giving your lecture of distinction. And thank you very much to everybody for listening. And just to let you know that next week's lecture is being advertised through the Facebook and through Instagram, etc. So please do join us about injuries of the midfoot. We'll be talking about Liz Frank, etc. So it all just says that we say thank you once again and wish you all a very good night.